p-value of 0.007, which is statistically significant. However, clinically, we would want to have more time to see an impact. More common adverse effects include rash or acne, diarrhea, and dry skin for both groups. Adverse events of grade 3 or higher were reported in fewer patients in the osimertinib group as compared to the comparator group. Each grade is defined by CTAE, common terminology criteria in adverse events. The higher the grade, which means the more severe the adverse event. As you notice, the second box, prolonged QT interval was noted more in osimertinib group of 10% and 4% in the EGFR TKI group. But good thing to note is that no fatal causes of QT prolongation occurred. Moving on, author's conclusion. So osimertinib showed efficacy superior to that of standard EGFR TKIs in the first-line treatment of EGFR mutation-positive advanced non-small cell lung cancer with a similar safety profile and lower rates of serious adverse effects. Strengths include that it was a randomized, double-blind international trial design. Stratification was by tumor EGFR mutation, status, and race. Their primary endpoint was statistically significant, inclusion of subgroup analyses in support of primary outcome, and finally, the use of the two most common EGFR TKIs. However, some weaknesses include that the baseline brain imaging was mandated only in patients with known or suspected CNS metastasis, with follow-up imaging in patients with confirmed CNS metastases. So the detection of asymptomatic patients with potential metastasis may be limited. Funding was done by the drug's manufacturer company. Lack of inclusion of comparator second-generation EGFR TKI, afatinib, although it wasn't approved as gold standard yet at the time. And lastly, the immature data on overall survival analysis was too early to tell. However, no worries, because a few years passed and we have the final overall survival analyses. As continued from FLORA trial, overall survival with osimertinib in untreated EGFR mutated advanced NSCLC. The purpose was to assess the final analysis of overall survival and safety of osimertinib versus EGFR TKIs as first-line treatment. Since it was continued from FLORA trial, the design remained unchanged, as well as the intervention and the funding. The data continued all the way until June 25th, 2019. The primary endpoint was the overall survival. Osimertinib had a clinically meaningful and longer overall survival of 38.6 months as compared to 31.8 months. It was statistically significant based on the p-value of 0.046, indicating a 20% risk reduction of death. The data was based on 58% maturity of the trial, with 321 deaths from the 556 patients included. Now, when we look at the subgroups, one on the left is overall survival curve for Asian demographic, while the other is non-Asian. If you notice on the Asian graph on the left, osimertinib actually crosses over and has less probability of overall survival than the comparator group after 38 months. The Asian subgroup had a hazard ratio of 1, indicating that there was no difference between the two treatment groups for the Asian population. Non-Asian graph showed a great separation between the curves, indicating a great benefit of osimertinib with an overall survival hazard ratio of 0.54. As expressed in this forest plot, the largest numerical difference between groups and the hazard ratios for overall survival were observed between Asian and non-Asian patients by looking at the distances between the two confidence intervals. Next, we look at the CNS metastasis with majority towards the left of the null line of 1, which indicates more benefit towards osimertinib than the comparator group. Looking at the EGFR mutation, exon 19 deletion had more benefit than L858R mutation, which had a hazard ratio of 1, indicating there's no difference between the two treatment groups of patients who have mutation L858R, which also means that patients who are Asian and have the L858R mutations did not show enough effect. Yes, I skipped a couple slides. Anyways, however, overall survival benefit with osimertinib as compared with comparator EGFR TKI was consistent across most subgroups. There we go. Safety profile was consistent with safety profile in the primary analysis of FLORA trial. The common adverse effects continued to be seen were diarrhea, rash or acne, and dry skin. Final conclusion from the author is that they found that first-line treatment with osimertinib was associated with significantly longer overall survival than treatment comparator EGFR TKIs in patients with EGFR mutation positive, locally advanced, or metastatic NSCLC, and has similar safety profile. So I also have some thoughts. Osimertinib showed superior efficacy for both prior EGFR TKI and chemotherapy, more tolerable and lower rates of serious adverse events. Further research of osimertinib with primary outcome of CNS efficacy for treatment or prophylaxis could be performed since FLORA study only included secondary outcome of CNS activity for patients who presented with and had symptoms of any CNS malignancies. If we included it as a primary outcome, we could include patients who are also asymptomatic by requiring all patients to receive a brain scan before treatment. The results of the FLORA trial of both progression-free survival and overall survival added clinically relevant evidence towards use of osimertinib in the first-line setting in the EGFR mutation-positive NSCLC, which is exactly the major breakthrough that resulted in updates in the National Comprehensive Cancer Network Guidelines, NCCN guidelines. Represented here, NCCN guidelines version 3 of 2020 of non-small cell lung cancer has added osimertinib as first-line therapy for EGFR mutation for previously untreated patients. But what does the future look like if progression occurs? Represented here is NCCN Guidelines version 3, 2020 of non-small cell lung cancer. We have a algorithm for patients who have progressed from osimertinib to either receive local therapy, such as radiotherapy or surgery, continue osimertinib, or at least at the last line on the right is listed. Therapy would include afatinib, the second generation, and cetuximab. However, this evidence category is only 2A, which is based upon lower level evidence. Immunomonotherapy is less effective, as seen in many studies. But what can we do if resistance and disease progression occurs while on osimertinib? Remember the star of the show that I mentioned previously? Well, liquid biopsy, or also known as plasma genotyping, and tissue biopsy are options that we can identify resistance. Liquid biopsy is a clinical screening method mainly for non-small cell lung cancer to detect characteristics of resistance mutations through circulating tumor or ctDNA. 30% are false negative and 70% sensitivity to T790M mutation. However, so if there's a false negative, I would want to make sure that the liquid biopsy had at least, T790 mutation and it showed negative. Because of its false negative tendencies, I would interpret it as not enough cell-free DNA circulating in the blood which means that tissue biopsy for confirmation would be necessary. Common acquired resistant mechanisms include 3 types, with the most common of target gene modification, then alternative pathway activation, and histological transformation, which I have listed examples after each. Being able to identify the resistance, finding the mechanism, then creating a drug to target the mechanism will be the most ideal. Osimertinib resistance mechanisms are varied, but here are some common ones found split between loss of T790M, since mutations become deleterious and cause loss of function for other mutations. Then, maintained T790M mutation has C797S mutation that also coexist. On the graph, you'll see that it is split between these 2 categories. So much more research is needed to find the next best treatment option after osimertinib. Here I have listed 3 trials that further study and understand resistance mechanisms after first-line therapy and determine appropriate therapies based on the molecular resistance profiles. Mariposa 2 trial compares amivantamab and lazertinib with IV chemotherapy, and Orchard trial is on a mission to find the best treatment based on a biomarker, while Savannah trial investigates combination drugs for patients with mutation of MET+ and EGFRM+. Osimertinib is preferred standard of care treatment for metastatic NSCLC patients with EGFR T790M mutations. The most direct way to treat osimertinib resistance would be finding the mechanism of resistance. In order to understand more mechanisms, further research would be needed, or actually would be more beneficial to obtain a more comprehensive non-invasive testing method to obtain post-progressive disease biopsy more rapid and more convenient. I want to thank my mentor and those of you watching. Thank you for your time and listening to me. I apologize about the random halfway through the presentation, I had to close the door. But please let me know what questions you may have or just some thoughts that you may have. Thank you. And I may have struggled a little bit with presenting, but this is still the pre, so thank you. And I hope you have a great rest of the day.